So I will be speaking on the updated efficacy and ctDNA analysis of patients with TRK fusion lung cancer treated with larotrectinib. So this was the updated analysis was presented in abstract form in the Annals of Oncology. It was by Moreno and et al. So just to give the background, I think a lot of the other previous speakers has given the background, but just in brief, NTRK gene fusions are oncogenic drivers in a wide variety of the adult and pediatric patients. The frequency of the NTRK gene fusion in NSCLC is less than 1%. So larotrectinib is a first-in-class, highly selective CNS active tropomyosin receptor kinase inhibitor approved by the European medicine agencies and in more than 40 countries worldwide. The larotrectinib has demonstrated an objective response rate of 75% across 2,206 patients with various TRK fusion positive tumor types. However, the TRK fusion cancers can develop resistance to first-generation TRK inhibitors because of the acquired on-target resistance mechanism due to the mutation in the kinase domain. And these mutations in the kinase domain will interfere with the binding of the TRK inhibitors. So this study reports the efficacy and safety outcomes along with the genomic characteristics of the patients with the TRK fusion lung cancers with larotrectinib, whereby larotrectinib is a highly selective CNS active TRK inhibitor, which has demonstrated an objective response rate of 75%. It also reports the efficacy and safety with the ctDNA analysis for patients with the TRK fusion lung cancers. So the NTRK gene fusions involve either NTRK1, NTRK2 or the NTRK3, which are the oncogenic drivers of the various adult and pediatric tumors. And this can be detected with variety of methods like the tumor DNA and the RNA sequencing or the plasma-free DNA profiling. And as I said, that NTRK fusion positive cancers has demonstrated an objective response rate of 75%. So this is how the NTRK fusions look. The gene 1 and the gene 2, there is a fusion between the gene 1 and the gene 2 lead to TRK fusion protein, and it leads to the activation of the downstream pathways, mainly the PI3K, the RAS pathway. So this study involved patients with the TRK fusion who were treated with larotrectinib in 2 clinical trials. The NTRK gene fusion status was determined by local testing prior to the enrollment. The larotrectinib was administered at the dose of 100 mg twice daily. The primary endpoint was objective response rate, which was calculated by using the RECIST 1.1 criteria. The ctDNA was analyzed using the liquid biopsy test by Garden 360 and Garden Omni, and the data cutoff was till 20 July 2020. A total 20 patients with metastatic TRK fusion lung cancers were identified, including 10 patients with CNS metastasis. The median age of the patients was 48.5 years, and patient had a median of 3 prior therapies. Among the 15 patients which were evaluable, the objective response rate was around 87%. Among the 8 patients with the baseline CNS metastasis, the objective response rate was 88%. The treatment duration for the evaluable patients ranged from 2.1 to 51.5 months. The median time to response was 1.8 months. The duration of response was not reached versus the 12-month duration response rate of 64%. The median PFS was around 33 months and the median OS was 40.7 months. Now, the genomic alterations were looked at by using the ctDNA analysis, which was evaluable for 14 patients, of which 13 had somatic alteration detected at baseline. The ctDNA analysis detected the NTRK gene fusions in 6 of the 13 patients, which came to 46% of the total population included. Co-occurring known oncogenic mutations were detected in 7 patients at the baseline. By the data cutoff, 6 patients had a progressive event with the ctDNA available for 5 patients. Potential acquired mutations were identified in 3 patients and which have been enumerated on the slide. So to conclude, larotrectinib demonstrated durable and robust responses, extended survival benefit, and favorable safety profile. ctDNA sequencing represents a promising technology, but its optimal integration into testing of NTRK gene fusions or resistance mutations still remains to be determined. Known resistant mutations in NTRK may cause progression, but further studies are still warranted. Thank you.